So welcome back everybody to the afternoon session. I hope you all managed to get a quick break, something to eat and a bit of a stretch. So this next hour we're going to be hearing from a number of different people, mainly focusing on symptoms and how those may affect people's ability to work. So we'd like to start off the session with Kate. Kate Duda is the manager for ME Auckland. And ME Auckland is a charity that provides support, advocacy and community connection for people living with ME/CFS, so with chronic fatigue syndrome and with long COVID. And just like to say how what a great support agency they are. So very delighted to welcome you, Kate, and yeah, please share your screen.
Fantastic, cool, thank you. So tēnā koutou katoa, ko Kate Duda, tapa ingoa. So just a quick intro on myself. I'm the manager and vice president at ME Auckland, as Mona said. I've got 20 years plus experience in the not-for-profit and community sectors, both internationally and in New Zealand. The majority of that focusing on community and organisational development. I also have ME, so really understand some of the experiences and the journey that people with long COVID are going through. And I've actually improved my condition enough to be able to work part-time now after being mainly housebound about 4 years ago. So yeah, a lot of understanding from my side of things. So ME Auckland is an Auckland-based charity that provides free support services for people with ME/CFS and long COVID and their whānau. We provide online support groups nationally, as well as dedicated one-on-one client support services for those people that are in Auckland. Our client support coordinators assist people with illness management information, emotional support, and advocacy for work, medical, and financial assistance. We also have a team of volunteers who facilitate regular face-to-face support groups in different areas of Auckland. We've recently rebranded, so you'll see the new brand at the bottom there. And I just wanted to mention this in light of some of the work that we've got coming up, so that if you see a new brand, you realise that it's us. So this new brand will be launching next month as ME Support, and it just reflects the organisation as we grow and the work that we do. So last year we were funded by Te Whatu Ora to produce an online support tool for long COVID, and that's due to be launched in March this year. The tool is going to consist of 13 narrated videos, and that includes what long COVID is, its symptoms and diagnosis, related conditions, various symptom management topics and strategies, such as sleep, pacing, pain management, POTS, which is a condition that's associated with long COVID, common treatments, nutrition, dealing with emotions and stress as well. We'll also talk about how best to work with medical professionals and where to get different kinds of support. So we've drawn on a lot of experience from the ME community, and all the videos that we've got are evidence-based, and also drawn a lot from experience of people with long COVID as well. So alongside the videos, we'll provide supplementary information, links, tracking sheets, and other resources that will help people on their journeys. So for this project, we interviewed 7 people with lived experience of long COVID and 5 New Zealand ME/CFS and long COVID experts. And parts of their interviews are included throughout the narrated videos, but we're also making their full interviews available for anybody who wants to watch them and learn more about the individual's journeys or the work and the research that people are doing in New Zealand. So, oops, wrong way, sorry. There we go. ME Auckland is also an employer of people with ME/CFS and long COVID. So we have both staff and volunteers with the conditions. And so we asked our community what matters most for them in their work roles. And the top thing was flexibility. It might be flexibility in hours or days or the work or location, sick leave, or it could be flexibility in just meeting times that with all staff and that sort of thing. They also said that their manager or employer having an understanding of the illness and how it impacts them is really helpful as well. Patients and consideration of their needs also came up. So patients, when they're dealing with symptoms that impact them and their work and people around them, just like any other disability in the workplace, you might have to have patience with somebody who has a disability. And consideration of things like noise for people who have sound sensitivities, seating, having a quiet place to work, using headphones or other physical or environmental kind of tools or strategies. So we put a couple of quotes on the screen here from some of our community. So somebody also said sort of patience when the brain fog kicks in and it takes a while for me to sort of explain things. Low sensory stimulation, so not having, loud music in the office. Understanding and empathy that not every day is the same, so which is very true for people with ME and long COVID. One day can be very different from the next. So we work with our staff and volunteers to work alongside them to meet their needs, and we find that actually that makes them more productive, it makes them able to contribute, and it also has a really positive impact on their journey because they get a lot from being able to work and contribute, and it helps them with their, I guess, their contribution to society and who they are and their identity as people. So working alongside them differently has a positive impact on both us as an organisation and the people themselves. So that's it from me. Very quick, short and sweet. Hopefully within those 8 minutes. If you've got any questions, feel free to email me at kate.d@meauckland.org.nz. Ngā mihi. Thank you for listening.
Thank you so much, Kate. That was great, and really looking forward to the launch of those tools. I know that many in the long COVID community are going to benefit hugely from them. So if we can ask you to stop sharing your screen, and then we'll introduce our next speaker is Amanda. Amanda's Associate Professor of Public Health at the Department of Public Health, University of Otago, Wellington, who is going to speak about why it matters to prevent infection. So she's got some of the evidence there for us around preventing reinfection and the risk of long COVID.
I'm going to be talking about reinfections and why that matters. And I'm going to talk about the drivers and the impacts of reinfection. And I'm going to talk about how we can take a public health approach to reinfections in the workplace. Understanding the drivers of reinfection is really important because that generates our strategies for prevention. And it's useful to think about drivers in terms of environment, pathogen, and host factors. Starting with the pathogen, as we all know, this pathogen, SARS-2, is mutating very fast and generating new variants all the time. Now, that's a problem for us because our immunity looks backwards at the infections in the past and the vaccines in the past, not forward to the variants that are to come. And that's one factor that's driving reinfections at the moment. What hasn't changed is the route of transmission. It's still airborne, and I'll come back to that point later. At the host factor level, there are multiple risk factors, but they're not generally that easy to change. Even mask wearing needs some communication support alongside to make it work. On the other hand, environments are generally strongly modifiable, and we can see that workplaces strongly shape infection risk. When we look at case rates by occupational routes and occupational groups in Aotearoa, we can see that education, hospitality, healthcare, those are top of the rankings in terms of occupational risk. Moving now to impacts, the evidence is still evolving. We don't actually have a long follow-up time yet to fully understand what's going on. The other thing is that something that's really different about this pathogen is that the number of reinfections is very unusual. We don't have anything else really where we would see commonly people having 2 or more reinfections in a year. Even influenza, that's a really common infection. For adults, you would expect to have maybe 2 infections in 10 years on average. So this is very new territory. Looking at the impacts of reinfection on individuals, as I say, it's early days. Individuals are reporting very varying experiences of severity with reinfections, and the research findings are reflecting that diversity of experience. So more work to do here. I'd like to talk about the US Veteran Affairs study because that's been in the news a little bit. Now, they didn't look at severity of reinfection. They counted the number of infections that people had experienced. And what they found was the rates of serious new health conditions increased with increasing number of infections. Now, there's a little more detail to dig into underneath that, but certainly that is a very concerning finding. And we can reflect that in that study, the participants had experienced generally 1, 2, or 3 reinfections. We have no idea what 10, 15, or 20 reinfections would look like. So how many times do you want to roll the dice? Looking at the population level, as we can see, reinfections are becoming very common, and that means that the impacts amplify in workplaces. It's not just staff being off sick, it's them being off sick repeatedly, and it increases the chance that somebody might come into work still infectious and then pass the infection on to their colleagues. And when you add long COVID into the mix, you can see why some sectors are already getting very concerned about workforce shortage. What does a public health approach look like when we think about reinfections? First of all, we need to apply the precautionary principle here. And in particular, that means taking preventive action until the risks are better understood. It also means participatory approaches. The people who are most at risk must be at the table when risk decisions are being made. COVID is highly transmissible, but it's also highly preventable using a multi-layered approach. But very importantly, the prevention measures must be equitable in their design and in their implementation. Finally, a reminder that the role of public health is to build systems to protect people. It is not about using people to protect systems. So in conclusion, current evidence and the precautionary principle highly support action to prevent reinfections. Workplaces have a vital protective role here. And just to remind you that airborne transmission is still the main transmission route, and that means that indoor air quality is a key workplace protection, highly effective. Finally, we need a public health approach to develop systems that protect individuals and population, and very importantly, those systems must be equitable. Thank you very much.
Just many, many thanks, Amanda. That was fabulous. And I think really important that you highlighted the importance of equity. That's something that hasn't yet been addressed throughout the morning, and I'm hoping we're going to come back to a number of times this afternoon, because clearly the people, as you said, the people who are going to be impacted most are the ones who we must have at the table. And when we're thinking about workplace, then we do know that different sections of the population have different workplaces, and those workplaces, as was mentioned this morning, will have different sick leave entitlements, which has a huge impact on how people can cope with COVID at work. So I'd like to move on next to Paul. So Paul is going to talk about brain fog and pain. Paul is a consultant child and adolescent psychiatrist and a specialist pain consultant at Counties Manukau Health. So Paul, can I ask you to share, please?
Kia ora maina, tēnā koutou katoa, ko Paul Vroegop tōku ingoa, ko tamaki makaoro, and ko te taitokoro te kāinga. So just a couple of disclosures. I mean, I work as a clinician and obviously work with people with chronic and persistent pain. Much of my mahi has been with people with chronic health conditions and kind of psychological sequelae to these, and I do also have significant lived experience of supporting whānau and friends who've got long COVID, ME, CFS, and other kind of chronic health conditions that are poorly perhaps managed and recognised. And I'm very familiar with a lot of the frustrations in dealing with services, including what I would say is a very fragmented health system and very fragmented disability system in this country. And I'm just going to talk very briefly about long COVID chronic pain and brain fog and some of the links between these. So firstly, just acknowledging that mahi is not being able to do our work or attend education is a significant marker for any illness severity. It's a marker for significant disability, and it's associated with poorer outcomes as well as poorer mental health outcomes. And so work itself is protective, and not working actually impacts on our well-being across all elements of our life. But of course, it's not the only thing that's important, as many people have said. And I'll say as well, I hope there's not too much crossover with many of the other fantastic speakers today. It's also, I find it useful to kind of remember that long COVID symptoms may be comorbid with pre-existing kind of chronic health conditions, mental health conditions, and other chronic medical conditions. Symptoms may also, in long COVID, has been shown to exacerbate a number of symptoms that may already be present for people. And there's lots of overlap between other chronic conditions like ME, like persistent pain, like mental health conditions, with sort of long COVID. And the effects of those of long COVID on us can be additive. So, for example, long COVID might cause a significant sort of widespread pain that can additively kind of add to your significant fatigue and brain fog, or you can develop secondary anxiety and depression, which can in turn impact on your capacity to work. So persistent pain in long COVID, chronic pain is very widely reported across a number of surveys with post-COVID syndromes. Of course, those are complicated by the fact that chronic pain itself is a very common condition across, probably about a quarter of our population generally. But there are certainly some pain conditions that have shown to have a markedly higher rate in people suffering from long COVID. So particularly musculoskeletal pain, headaches, chest pain, testicular pain is another one, and abdominal pain is another. Brain fog's a really interesting kind of concept, and it's worth noting that that brain fog and fatigue, particularly cognitive or mental fatigue, there are a whole lot of changes that go on in the body that kind of we think leads to some of these processes. So one of the things that's sometimes useful, I feel, in talking with people is thinking about this idea of interoception. So the nervous system detection of bodily changes, signals that originate within us. And, our brain does this job of integrating those internal signals to kind of maintain a homeostatic control and help our self-awareness. And there are whole circuits that kind of lead to that, which is the things on the right-hand side, which I won't go into. But we have a number of kind of brain neurological and hormonal circuits that lead to fatigue, including cognitive fatigue. And it's also worth just remembering, as everyone I'm sure here knows, that physical energy and cognitive energy are kind of, they often come from the same basket, a lot of people describe. So brain fog itself is a very fuzzy concept. It's kind of an umbrella term, and a whole range of different cognitive symptoms, everything from dull thinking to attentional difficulties. It requires more effort to think. It's hard to concentrate. It's difficult to make decisions, feeling confused, thinking more slowly, fuzzy, forgetful, struggling to find words or get concepts across, and mental fatigue or exhaustion. It's really commonly seen in people with long COVID and other post-viral syndromes as well as a number of other conditions. So it's a very general kind of term. It's important to note that it's usually associated, brain fog is usually associated with normal cognition. It's not cognitive dysfunction or cognitive disorder with it. And there is some evidence, going back to interoception, that our focus on the effort of how effortful internal cognitive processing is may well be a critical part of the experience of suffering from brain fog. And awareness of how effortful thinking is may then worsen our experience of cognitive dysfunction. Now, just moving on, I'll briefly touch on barriers to recovery. And I guess there are similarities with lots of conditions, including chronic pain and CFSME. One of the issues that I think has already been mentioned is long COVID is an invisible illness, and the stigma that goes with that, which engenders a whole lot of beliefs, both sometimes within sufferers, but also within people around them and even professionals, that, long COVID isn't real, that people who suffer from it are just avoiding or just lazy or anxious. And these are really, really profoundly unhelpful messages. And some of the things that go with that are also this idea that, actually you shouldn't do anything whatsoever sometimes, that all work is bad, rather than a more nuanced approach to actually modifying how we might work. And there's also the kind of messages that we get that come from these kind of this kind of stigmatizing ideas that you should just ignore it, just go on, just take a concrete pill, but there's lots of evidence that can make things a lot worse for a lot of sufferers. And lastly, just acknowledging that how difficult it is for other people often to recognize just how much effort a person suffering from long COVID may require just to undertake minimal normal activities, or just to think, or just to answer a question, or to have a conversation for 5 minutes. A bunch of other kind of barriers to recovery. Support groups are mostly absolutely fantastic, but I've certainly seen them have some downsides at times, particularly the kind of distress when people see, people who've suffered very severely and kind of feel like that's where I'm going, that's where I'm heading, that kind of expectation. Boom and bust patterns are supremely unhelpful a lot of the time. And it's worth acknowledging that disability support services, as have already been said, are really hard to access in Aotearoa. Our financial support structures tend to be binary, although this morning's session, that was a very useful kind of kororo. And sometimes there are perverse incentives in terms of kind of recovery. So in terms of managing brain fog and fatigue, there is no one answer. The kind of approaches, if you like, are very that we know are useful, are very much are very similar to a number of other chronic kind of disabilities or conditions. That sort of very, very gradual, very, very person-driven and very individualized, multimodal kind of rehabilitation is the thing that's going to be helpful for most people who suffer. A huge part of that, though, is education regarding long COVID symptoms for sufferers, for whānau and employers, management of associated conditions. And, it's often said about, health coaching, problem solving, CBT, those kinds of approaches, they're not going to fix long COVID. And no, they're not going to fix long COVID, but they can help us. They can help people to support their own kind of self-management and their rehabilitation and recovery, and flexible financial support. So look, in summary, brain fog, chronic pain are really common in people suffering from long COVID. Aims of recovery should really focus on trying to get life back and get a life worth living back. I'm not saying we shouldn't aim to cure cure symptoms. Don't get me wrong at all about that. But I'm just saying we have to deal with helping people the way things are for them now. And that's a kind of graduated process. Energy budgeting is really critical. Work can be really good for recovery if it's possible, if managed appropriately and sensitively and progressively. And identifying barriers can be kind of really useful. Kia ora, thank you.
Kia ora, Paul, that was fantastic, thank you. And I hope many of you out there who know a bit less about long COVID have really benefited from hearing Paul talk. So I'd like to welcome our next speaker, Emma Davidson is an occupational therapist and clinical advisor with APM, who's going to talk about managing fatigue and return to work. So welcome, Emma.
Anyway, managing fatigue, this will be fast, so apologies in advance. Next slide, please, Rochelle. Fatigue and COVID. So the actual figures on the experience of fatigue with acute and long COVID may vary depending on the literature that you're reading and the scope of it. But I think we can feel confident that a good chunk of people experience ongoing fatigue or post-exertional malaise, as professional groups call it, following COVID infection. In this context, fatigue isn't just feeling a bit tired, it's a response that's in excess of what we would expect for the type of activity completed. It's more like the exhaustion to one's bones type describer. The onset can be quite delayed and unpredictable, which can make it really tricky to manage. We know that many things influence fatigue in general, so we also need to make sure that we're meeting these needs of people, and it often warrants a multidisciplinary team approach. One of the biggest challenges, Paul's just touched on it as well, is that the symptom really is invisible. Oh, you look fine, what's the big deal? It's really challenging, but it is a really genuine experience of the people who are working through it and a real challenge for them to manage. Management of fatigue and post-exertional malaise requires prioritisation of activity management or pacing, ideally as part of an NDT approach to long COVID. If we can move on, please. So what's pacing? It's known as many things: activity management, energy conservation. They're all synonymous and essentially mean the same thing. To pace is to be careful not to do something too quickly so that it can't be finished. Pacing should be considered within an individual task, across a day of tasks, and across a week or more. In my opinion, that last one is what's often overlooked, and it can be really, really important in a work context. Next slide. Pacing aims to prevent boom-bust behaviour, doing too much when you're feeling good and then crashing later. We know that boom busting has a negative impact on activity tolerance and general engagement in activity over time. Next slide. Conversely, we know that when a person paces well, there's a positive correlation in activity tolerances and engagement. The key principles in pacing are the 3 Ps. Some people use 4 Ps, some people put some Ds in there, but we're going with 3 Ps. So what are they? Prioritising, sitting down and thinking about what has to be done, what can wait, what things are essential. Really important is what do I want to get done versus what's not so much of a priority right now. Planning and positioning is really great. This can be super empowering. It involves mapping out activities across a day and a week or more, in a work context especially. Educating others in the workplace, the people around the individual, it can be used to help gain understanding and support when people understand the approach that someone's taking and why they are doing it. It can also help to boost confidence, so providing reassurance that a person's going to be able to do what they need to be able to do across their week. And pacing, of course, balancing activity patterns, breaking things down into manageable steps, and ensuring activity levels are achievable on good and bad days. The phrase only doing today that which you can do again tomorrow is quite a good mantra to think about in this context. Next slide. When we talk about pacing, we talk about an energy envelope or envelope, depending where you come from. This is the amount of activity that someone can do without their symptoms worsening. Once someone's on top of their symptom load and their energy levels are quite stable, we can look at incrementally increasing their energy envelope. We expect that any increase will result in a bit of an exacerbation of a person's symptoms, but if it's done in the right way, it should be manageable. If it's more than a mild increase, we might drop back the amount of activity that they're doing slightly and then try again later once their symptoms settle. Next slide. With pacing, I personally really like the Parkwood approach, and it can also act as a really nice visual of the concept. The green section at the bottom is essentially a person's energy envelope. The one point that I want to make is that with the long COVID group, they are different to other groups of people that we might work with managing activity. So with long COVID, there is significantly less flexibility for pushing tolerances than other population groups. So generally with fatigue management, we can encourage people to sit primarily in the green zone and gently nudge into the orange or yellow on this graph quite regularly. With a long COVID group, we would expect that nudging to be much less, and it's really only when you're ready to incrementally increase an energy envelope that you'd be doing that. So if you take nothing more away from the 8 minutes that I've got today, that's the one thing I want you to take. It's super, super important in long COVID recovery. Inherent in pacing is good awareness. So awareness of the effective activities, of a person's current limitations and what they need to do to manage their energy. There's lots of ways that we can support a person to develop their awareness. Some of those are on the screen, but there's some things we also need to bear in mind depending on the individual that we're working with. So for example, we want to help a person develop awareness, but we don't want to be promoting hypervigilance or a really heavy focus on symptoms. And we don't want them to become fear avoidant, where they're too scared to do anything for fear of exacerbating their symptoms. We also want to help a person develop strategies so they can be responsive to their body and their daily demands and what they need to do, without being really rigid about what type of activity they can do and when. It's a very fine balance. So some final points to consider before I sign off. Pacing is a very simple concept, but is definitely not easy to do. It's so different to how many people are used to living, and it takes time to adjust and get it right. I love the 70% rule for work. That ensures that a person can still engage in other meaningful activities outside of work, and it supports sustainability. Terminology can be really important, and it does depend on the person. Sometimes there's quite negative connotations with the words fatigue, so energy might work better. And it's the same with using rest or break. Some people really do need to peel back their activity though, so those are the types that you might really adhere to rest. The focus should be on what someone can achieve in their day rather than just how their symptoms are presenting. And also think about the psychological needs. For many, do they determine their self-worth by what they can do in a day? And there's others that use things like exercise as really great everyday coping mechanisms. But if they can't do that anymore, how are we supporting them? So that's where we might lean on our MDT more. We need a greater return to work and pace across a week. And then there's some resources linked at the end.
Thank you. I'm so sorry to cut you short because it's really, really interesting and useful stuff for everybody to hear. Really appreciate the time you've put into that. And I think having those slides afterwards will be fantastic for those resources. So thank you, Emma. And I'd like to invite Sarah to speak next. Sarah is a cardiorespiratory physiotherapist and a lecturer in the School of Physiotherapy at the University of Otago, and is currently working on some long COVID research as well as practice. So Sarah, handing over to you.
And for some reason I can't move my screen on. There we go. Okay, so POTS, or postural orthostatic tachycardia syndrome, is just one form of dysautonomia under the umbrella of autonomic dysfunction. It's a common symptom in those people with long COVID. So a gold standard diagnosis is via tilt table testing, but in practical reality, it's often done via an active stand test, which involves a participant or patient standing for 10 minutes and looking at the elicitation of those typical symptoms, as you can see on the screen, and an increase in heart rate of greater than 30 beats per minute, which is sustained over time, and in the absence of a marked decrease in blood pressure. How prevalent is it? There were 2 studies that came out last year with an estimated prevalence of POTS following COVID-19 of being somewhere between 14% and 30%. A further study that was published late in 2022, sought to characterise symptom burden in a survey of over 2,000 adults with long COVID, and found that 66% had a symptom score that was suggestive of moderate to severe autonomic dysfunction. So I think it's safe to say it's quite common. There is a clear overlap with breathing pattern dysfunction. So a study in 2020 found that 80 to 90% of those with POTS assessed by a respiratory physio had dysfunctional breathing or hyperventilation syndrome, and that with breathing re-education, there was a reduction in these symptoms. As we've heard earlier today, or quite recently in the previous presentation, with lots of long COVID symptoms, POTS is often invisible, so hard for people to understand. We know that the medium to long-term prognosis is not well understood, but there was a report published in the British Medical Journal last year that suggests many patients do recover spontaneously within 12 months. That doesn't mean it's easy to live with. In terms of management, patient education about the condition and non-pharmacological management is key. However, it's important to acknowledge that there is a role of medications in management for some patients, predominantly the use of beta blockers and fludrocortisone. Fluid and salts are key, so staying well hydrated is really important, and consuming sufficient amounts of water, and using something like the urine indicator chart here keeps people on track. Salt assists with the retention of fluid, and it's important to consider electrolytes to combat fluid loss through sweating, particularly in hot weather. Compression garments are recommended. They need to be medical grade, and for most effectiveness need to be worn from ankle to waist level. Some experts are recommending the use of skins, as these are more acceptable to wear in that they're normalised and worn by many people who don't have POTS, so there's less stigma attached to wearing them. Large meals, which divert more blood to the gut, can exacerbate symptoms, so are best avoided. And exercise is important in the management of POTS. Where symptoms are severe, this needs to start with strengthening exercises in supine or even just initial static muscle contraction work, progression to recumbent exercises, such as swimming or the recumbent bike, and then further progression to other non-standing exercises, such as rowing or cycling. But it's really important to stress here that progression needs to be gradual with really careful monitoring of symptoms. Screening for other associated conditions is also important, as these need to be managed too. And there's just an example of some of those more supine or reclined based exercises for people to start off with. From a patient's perspective, having POTS is often a search for answers, not being believed, being written off as having anxiety. It's all in your head is a common refrain. We've heard that already today. A feeling of knowing something's wrong, but not knowing what it is, which speaks to the invisibility of this condition. And it's severely debilitating in some cases. So that inability to maintain an upright position limits function enormously, as you can imagine. And that leads to frustration at not being able to do things that people previously could, which obviously feeds into that loss of self. So that inability to fulfill roles that are important to the individual. Improvement can be slow and is not linear. So there will be better days and not such good days. And there's a link to a patient support group in the resources at the end of this presentation. So what do employers need to know? Anything that involves lifting or taking the arms above the head is going to result in an increased workload for the heart, and that is likely to exacerbate symptoms. So jobs that involve those activities need to be reconsidered. Prolonged postures can exacerbate symptoms as well and be a trigger. We typically think about prolonged standing because of the venous pooling in the legs, but for some people, prolonged sitting can be a trigger as well. Heat causes dilatation of the blood vessels, which can also worsen symptoms, and this has implications for avoiding hot environments. And as we've heard earlier today, some people will have increased sensitivity to bright lights, to loud noises, and to busy environments, so trying to reduce the stimulation. And I just want to mention stress, because obviously people with POTS already have autonomic dysfunction, dysregulation, and high levels of the release of something like noradrenaline can further increase heart rate and obviously provoke those symptoms that they're experiencing. So what does this mean from a working perspective? The flexibility at work is really, really important, as POTS has a variable impact on people. So different people will have a different experience. The use of conventional return to work strategies, such as 3 mornings a week, building up to 5 mornings a week, and then gradually building on that, is not necessarily helpful in this population. So people may need to commence work and build up at much lower levels, and it's really important to monitor symptom response to any change in work. Time off for treatment. So this might be time off to access treatment off-site, but it may also mean time off within the working day, on-site, to use relaxation techniques to manage that breathing pattern dysfunction. So provision of a quiet area if possible, where people can go to lie down, practice relaxation and breathing exercises, instead of the alternative hustle and bustle of the staff room, for example. Ergonomic changes to an individual's workspace, such as options to work in different postures, can be helpful. In terms of task modification, switching someone to tasks that are perceived as less physically effortful can be helpful, but that could be counterproductive if the replacement tasks are new and unfamiliar, as the added cognitive effort could actually worsen symptoms and act as a trigger. So other recommendations: controlling temperature, so that might just be provision of fans to increase airflow and reduce the heat. Regular work breaks, not just for rest, but also to ensure people are able to consume fluids to maintain levels of hydration, having a flexible dress code to reduce that stigma and enable people to wear compression garments comfortably. And as we've already heard from Kathy and Paul today, there are hugely detrimental impacts of not being able to work. So trying to work with that person to enable them to continue work in some capacity, recognizing that it affords self-worth and social connection. And finally, supporting people to see the skilled professionals that can help in the management of symptoms. So physiotherapists, occupational therapists, in some cases, cardiologists. Thank you.
Thank you so much, Sarah. That was really clear and some really, really practical takeaways from that talk. So as you can see,
I'm very fast.
Emojis there coming up. There's lots of support for that. So many, many thanks. I'd now like to pass on to our last speaker in this session, Denise Quinlan. Denise is going to speak about grief and long COVID. So we know that for many people, long COVID has taken away their lives as they knew it. And so this is a really important area. And yeah, delighted that Denise is able to speak today.
Thanks, Mona. And I want to begin by thanking everybody who's spoken at this session. I have learned so much from you, so thank you. Tēnā koutou katoa, ko Denise Quinlan aho, na mihi kia koutou katoa. So what I am going to talk to you about today is essentially the invisible part of an invisible illness, the grief that is associated with long COVID, which, and I know that there was a request for me to speak today from people suffering with long COVID who say, talk to us about the grief. So my name is Denise Quinlan. I'm co-founder of the New Zealand Institute of Wellbeing and Resilience, and we're psychological resilience and wellbeing academics. We've focused on resilience and loss since 2014 and bring together contemporary grief theory with resilience research to give people tools so that you can be active participants in dealing with your loss and live and grieve at the same time. And one of our key messages is you can and will get through this. On the screen there are links to some of our free resources, which I will share with you at the end. So in terms of what I want to try and talk about with you today are to say, what is the grief and loss of long COVID? That it is real. To talk about a current model of grieving, maybe retire some old stuff, the importance of relationships in grief, and to share with you just one evidence-based coping strategy that may prove useful for people with long COVID. So, first of all, as Paul said, long COVID is real. And I want to add, the grief of long COVID is also real. As well as the primary loss of health and capacity, there are secondary losses that can include concrete, like loss of income, a loss of, relational, loss of colleagues and community because you can't share the same activities, but also loss of identity. Your role as a provider, your future plans and ambitions. So this is real loss, and it has a significant impact on people. What we know about loss is that significant loss tears apart our existing view of the world, our web of relationships, and it literally catapults us into a new world. According to Professor Tom Attig, who is a world authority on grief, the primary job of grief is relearning how to live in the world. You will do it, and it can take time. So how do we do that? And the answer is that we manage our grief in bite-sized chunks. Many of you will be familiar with Kubler-Ross's 5 stages of grief. Now, interestingly, when that has been studied, there's no evidence that supports it. In contrast, since the 1990s, contemporary grief theory focuses on a dual process or an oscillation model that more accurately reflects how people grieve. People move between experiencing or expressing their grief and being able to focus on the practical jobs of living and work. And that is all part of the process of grieving. People need to move between the two poles. Some days you may not be able to face your grief, and being absorbed in work is really helpful. On other days, people are confronting their grief and may not actually be able to face much work. And we need to expect that that will continue for some time. So I feel like this adds, I'm echoing what so many other people have said in terms of the importance of communication, flexibility, and this being nonlinear. Another aspect of the grieving is relationships are really important in coping with loss. But the sad truth is that they can be hard. And just for anyone living with long COVID, yes, social ineptitude is a real phenomenon. It has been studied. We know that when we're grieving, people don't always do what we hope. They give us unhelpful advice, they avoid us, or they fail to provide the support we've really hoped for. And the practical suggestion to all of this is relationships are important, even when they're hard. What's really helpful is to say, don't be a mind reader. If you are a supervisor, a colleague, or a helper, ask someone with long COVID what will be helpful, what they want and need. People with long COVID, ask for the help you want. We do need to speak up to get what we need. And I want to just share with you something that I think provides a source of hope and optimism, some good news. There is solid evidence that has been building over more than 2 decades that the experience of positive emotion and experiences can help coping with the significant life challenges. Now, in particular, this work is studying the challenges of severe illness and bereavement. So Professor Judy Moskowitz is based at Northwestern Uni in Chicago, and this work, these programs of work, have been done with patients, their carers, and the bereaved, looking at the experience in areas of HIV/AIDS. They began that work back in the 80s when that was a fatal illness, with diabetes, with stage 4 breast cancer, and with dementia patients. So this is a significant body of work that has been able to show that when we can encourage people to experience more positive emotion in their day, their coping and their quality of life is significantly enhanced. So how do we do that, especially on the days when we don't feel like there is anything positive going on? So in the programs that have been taught across this research over the past 2 decades, these are 9 practices that have been reliably demonstrated to help. And as Judy says, there's a buffet of skills. You don't have to do them all, just the ones that actually appeal to you. They include the practical and simple things of noticing what's still good, what we can feel grateful for, of savoring the good stuff. I always describe that as not letting the good things get squashed out of your day, actually paying attention and give them some space. Benefit finding the silver lining where you can. And crucially, I think too that we ignore at our peril are being kind to ourselves and others, and the importance of self-compassion. Beating ourselves up for what we're not able to do has never been proven to get anyone any closer to anywhere they want to go. It actually really gets in the way. So attainable goals, and I know anyone who's listened to the work on pacing will know that some days that's getting the sheets out and putting them on the bed before even making the bed. So practical attainable goals really help. And I just want to finish by saying to you, we have been approached by so many people who want help to cope resiliently with the grief of long COVID, that we have said we're looking at creating a new course specifically for this and looking to workshop it with people who are interested so we can make sure it best fits their needs. If that's of interest to people, you can use this, scan this code on your phone or find it on the university's website. It has links to any of the resources. We've got a resilience tip sheet, some podcasts with people like Judy Moskowitz, Lucy's TED Talk that was in a top 20 in top 20 globally on the 3 secrets of resilient people. If you are interested, please contact us. We'd love to stay in touch. And thank you for listening today. It's been a pleasure to be part of this symposium, and I wish everybody well. Thank you.
Thank you very much, Denise. That was a very powerful way to end this session. So many, many thanks for your talk. I'm going to pass over now to Hayley, who's been looking at the questions and answers, and she's going to direct questions towards all of our speakers who are going to form the panel for the next 10 minutes. Hayley.
Kia ora. Thank you, Mona. Kia ora koutou. Thank you all for an amazing session. I have a page full of notes here and, of course, our questions and very good commentary from the Q&A chat. I might kick off with Amanda just to ask, Amanda, what do you feel is the role of public health when it comes to long COVID?
Kia ora. I think we in public health have a very strong role here. There are probably lots of things we need to do, but what I'm thinking today is really 2 main issues where we can contribute. One of those is in policy, and the other is in evidence review. So from the policy side, when we think about public health, I mentioned in my talk, we think about building systems, we think about structural level effects. And a lot of those levers are up at the policy level, and they're held by government. So one of our roles is to hold government to account in terms of providing the structural level support that is going to be needed for this public health problem. So that's one thing that we are doing and will continue to do. The second thing is slightly different, is evidence review, and that's because the basic science of public health is epidemiology. And what that really is about is evaluating patterns of health and disease in populations that might not be visible to one person on the ground with their individual experience. And that means that epidemiologists are trained and well prepared and well positioned to evaluate evidence that's changing, that's uncertain, that's complex. And I think this is an important role for us to play here, where the evidence is evolving very fast. And we have quite a few tools in the toolbox to try and understand what's going on. So I think those are 2 main ones. And I'll probably stop there because I know we're a little bit short of time.
Kia ora, Amanda, thank you. And we've got 5 minutes left, and so I might go to one that is quite topical at the moment and come back to you, Amanda, before talking to the rest of the group. There's a question in the chat about, is there any research into the long-term impact of repeated infections in children, especially as vaccines aren't available for under 5? And that would be great to hear from you.
I beg your pardon, is that for me too?
Yes, sorry.
Yes, I didn't hear that very well. Yes, there is research going on. I will say that I think children have been left out of COVID policy right through the pandemic. I think this is a huge gap. And what it means is we're not set up with the cohorts and the long-term evidence that we need to look at what's happening for children. And we really don't know very much about what repeated infections are doing for children, but honestly, from a precautionary, basic common sense principle, we have a new pathogen. It's spreading around the world. Surely one of the first things you do is to protect children, sit tight, look to see what's happening before you let your whole child population get sick. So I'm very disappointed with what has been happening around the world. I think the under 5 vaccine question also means that this is now our most exposed population age group. And data from the Well Kiwis cohort last year showed that a very high proportion of under 5s got sick last year. We don't know what that means for children. They are growing and developing, and we don't know how COVID is going to interact with that. So I think it's just really a huge evidence gap now that needs to be filled very fast.
Good, Amanda, thank you. That leads, I think, very nicely into my next question, which came up at the top of the hour in regards to equity. And so I'd like to extend this out to the whole panel, whoever would like to answer, including Mona, because I know you've expressed an interest in this as well. Would be great to hear from anyone. What is the ideal equitable public health approach in your opinion?
Well, I guess I'd just like to reiterate what I think it was Amanda who said, that if we don't have the people who are most affected at the table, we'll never get our public health approach right. And we saw that really early on with the government in the COVID response. They completely ignored the very, very strong and coordinated Māori response. There was virtually every Māori epidemiologist and public health physician who is in the country were involved setting up to whakapapa uruta, and that was ignored for a long time. And it wasn't until the vaccine rates for Māori, very predictably, because Māori weren't involved in the design of the rollout, were low, that people started listening. And that's something that has to change. If we want anything to happen that involves the entire population, we make sure those people who we know from every other example are going to are less likely to benefit from a whole of a population approach are at the table, because we also know that things that work for Māori work for everybody, and it doesn't work the other way around. So I would, I'm very, very adamant that that is how every future policy needs to be considered, that that equity is at the absolute heart of policy decisions.
Yeah, I would agree with Mona on that. I think we need to be amplifying the voice of all of those communities that historically don't have a voice. So the Māori communities, the Pacific communities, the disabled communities, the people that live rurally, that have really poor access to healthcare relative to the urban centres. And that needs to be the cornerstone of how we move forward.
I'd like to make a couple of comments just on the upstream idea of preventing infection, and the notion that I think we have to act collectively, that is all together. And the more work we do to prevent infection, the better. And in my view, and I think the view of others, it's desirable that any preventive actions are able to prevent the infection for everyone. I think that's simply better than you do you, which has been demonstrated to be not effective enough. And I'd like to make a plea for, I guess, policy and building systems, as mentioned by Amanda. So please, any action on that would be great, and in particular around ventilation, which doesn't require any individual's action for it to be effective, and it is effective.
Good, Stuart, and thank you everyone for those remarks, and wholeheartedly agree. I might hand over to Mona now to close our session. Thanks very much.
Oh, thank you, Hayley, and thank you again to all the speakers and contributors on the questions and answers. Yeah, really great to see such engagement, as well as all those reactions going up as all the speakers were speaking. So we will take a 5-minute break and be back in 5 minutes to start the next session. Thank you.